Alright, folks, today we're really going to get into the 12 lead EKG stuff. I did make this PowerPoint last semester for a group that was specifically part of the Butler County EMS system, or EMST. That was all the students that were taking the class. So you may see some references to Butler County, but I am going to kind of relate it to the real world and correlate it to anywhere that you may be working as an A. So we'll go ahead and get started. What we're going to do here today, talk about some 12 lead basics. We're going to go through our 6-step method of EKG interpretation. We're going to talk about STEMI information, not just with Butler County EMS, and we'll kind of broaden that out so we just cover everything. So right now, we're going to just take a brief moment to talk about our 6-step method of EKG interpretation. So the good news is that you guys got a lot of this down already. For example, step 1, our rate and rhythm, you should have down. Our QRS duration, you should be able to figure that out. Morphology of our complexes, should be able to do that. The things that we're going to really emphasize on are our axis determination, the STEMI mimics, and then ischemia, injuries, and infarctions. Step number 7 down there is a rule that you should always correlate your findings on your EKG to patient presentation. If you remember, we talked about asystole. If you have asystole on the monitor, but your patient is sitting there talking to you, more than likely you don't really have asystole. You got a problem. So that's what patient presentation is really talking about, and you should always do that with all your EKGs. So first, we need to decide when are we going to do 12 lead ECGs. You're on the EMS call, you decide you need to do one. At what point in the call should that be performed? So considering our ACS symptoms patients, the chest pains, shortness of breath, pain radiating the jaw, etc., we need to be doing these with the first set of vital signs on the appropriate patient. If you're sitting in the sitting in Chili's and you have a female patient, probably not appropriate to disrobe her and do a 12 lead in front of all the other patrons. So when it's appropriate, you should do your first set of vital signs as soon as possible. We should try and get our first 12 lead tracing before we provide oxygen and nitro if the patient's not in severe respiratory distress. Obviously, airway, breathing, circulation comes first. We should do this before moving to the truck if it's not necessary to protect the patient's dignity, like we just discussed. Ideally, our first 12 leads should be recorded within 5 minutes of medical contact. Now we've determined when we're going to do it, we need to know who we're going to do these EKGs on. So obviously, our main ones, we're going to be doing them on our chest pains, atypical chest pain, epigastric pain, especially in females, back, neck, jaw, or arm pain, even without chest pain, palpitations, syncope or near syncope, pulmonary edema, exertional dyspnea. We'll be doing them on patients that are, generalized weakness, diaphoresis unexplained by ambient temperature, feelings of impending doom, suspected DKA, hypertensive crisis, unconscious, unresponsive patients, nausea and vomiting, and post-cardiac arrest. Okay, you'll have to forgive me. I'm just coming back from doing some more EMS stuff. So I kind of forgot where we left off. We're talking about indications for 12 lead EKGs. Continuing on here. I think we kind of went over all of those. So now we're going to talk about lead placement on our 12 lead EKG. So whenever we are setting up our 12 lead, we need to remember that when we put our limb leads on the left leg, the right arm, left arm, and right leg, they do need to actually go on the limbs. You'll see a lot of times people are putting them on the trunk, on the chest and abdomen. We really do need to be conscientious of the fact that to get the most appropriate tracing, we do need to put those on the actual limbs. Try not to put them directly over a bone. Put them on a area where there is, some fleshy tissue. Usually down near the wrist, down by the ankles is a good spot for those. Whenever we're placing our precordial leads or our V leads, our first V1 is going to be located at the fourth intercostal space, just on the right sternal border. V2 sits directly across the sternum from it on the left side sternal border. V4 sits at the fifth intercostal space, mid-clavicular line. You're going to split the difference with V3, placing it directly between V2 and V4. V5 is located between V4 and V6, and V6 is located on the fifth intercostal space, mid-axillary line. Remember that the intercostal space runs fairly parallel to the, in the human body. So these should be in a fairly parallel line, straight across from each other. They shouldn't be. You see a lot of times some misplacement of the precordial leads. Make sure these do sit in a straight line. They should not be dropping or rising because they do run along. They're supposed to run along that intercostal space. So whenever we do our 12 lead, what are we actually looking at? We've already kind of discussed what we're looking at in relation to leads 1, 2, and 3, and then our augmented voltage leads are right, left, and foot. Remember that these are cameras. We're just looking at different parts of the body. Our limb leads are using 2 leads. One of them is a negative and one of them is or 2 electrodes, one negative and one positive to obtain our tracing. And then our augmented voltage leads are using the Wilson central terminal or the center of the heart as the negative lead, and then the depending on what the augmented voltage lead you're looking at will tell you what your positive electrode is. Our precordial leads are similar to the augmented voltage leads in that they use Wilson central terminal in the center of the heart as the negative electrode, and then the electrode that's placed on the skin is the positive electrode. So we're looking at different things with each precordial lead, and we'll kind of talk about what we are looking at with those precordial leads on the next slide. So whenever we already discussed the fact that our leads 2, 3, and F are inferior leads. They're looking from the bottom up, so they're really good leads for looking at the bottom of the heart, usually the right coronary artery. So anytime there's a infarction or injury located in this artery, these are going to be the leads that we look at. Leads 1 and AVL are very good at looking at the lateral, left side of the heart. Lead 1 is the high lateral, AVL is the high lateral. And then V5 and V6, which sit around on the fifth intercostal space in that mid-axillary area, are also good at looking at that lower lateral side. V1 and V2 are looking at the septum, the left anterior descending artery. V3 and 4 look at the anterior side of the heart. And AVR is kind of a throwaway lead, don't really use for this particular what we're talking about now, but we will discuss it in detail later on. So we remember that, like we already discussed, these are cameras that are looking at these specific areas. Notice that as we put our 12 lead on, these leads or these electrodes wrap around the left side of the heart. The reason for that is that the left ventricle is so much larger than the right ventricle. It has the majority of the electrical impact within the heart as a whole. So this is what we're predominantly looking at whenever we do our 12 lead, is the left ventricle. So if we were to try and look at the right ventricle, we would have to augment our placement to do that. And we'll talk about that, our right-sided 12 leads, at a later time. So graphic representation of what we're looking at with our 12 lead EKG. Starting kind of at the top left here, we see AVR. What that's looking at is kind of a transverse picture, since the electrical conduction is flowing down from the right atrium down to the apex of the left ventricle. AVR is looking backwards, which is why it's always should be a negative deflection. And that kind of gives you the hint of why that's more or less of a throwaway lead for looking for ST elevation. Going down and around, you see leads 3, AVF, and 2. Like we said, those are inferior leads looking at the inferior wall of the heart, generally the right coronary artery. We look on the top anatomical position, left side of the heart. We see leads 1 and AVL. AVL looking at the high lateral and 1 looking at the high lateral side of the left ventricle. And then we move to our precordial leads, and it's kind of hard to see those, what they're, the ones that are on the anterior portion of the heart. But we can kind of see them there, V1, V2, V3, V4, through V6. And notice that where those are looking at, that's kind of just a good representation of what we're really looking at as we move around that heart wall. You'll also see V4R, which we'll talk about in detail later. That's the V4 right. It's placed in the same location as V4, but on the right side. This is a good idea to do whenever you're dealing with certain types of MIs, and it does give you a better picture of the right coronary artery and the right ventricle. Again, here's just the superior view of the heart, the anterior side at the bottom of the screen, posterior towards the middle there, with our lead placement superimposed. So it's kind of easy to see V1 and V2. And just imagine that there's a straight line coming out of those electrodes, the V electrodes, and that's going to show you where they're looking at on that heart. All right, so moving into our interpretation of the EKG. Our first step is to determine the rate and rhythm. We're not going to waste a lot of time on step 1 because that's what we've been discussing for the last 5 PowerPoints. There's no difference in determining the rate and rhythm in a 12 lead than there is in a 4 lead. So everybody should be able to calculate the rate of an ECG and tell whether it's regular or irregular. So we're going to move on. So step 2 is the determination of the axis. What do we mean by axis? We're going to talk about axis determination here, why it's important to me. My opinion on determining axis of the ECG in the field, it is not taught very well in most settings in the classroom today. I do think that axis is very important. It plays an important role in seeing subtle changes to the ECG. It's difficult to have a really good feel for the ECG without having a good understanding of the electrical axis. Without a good understanding, it is, like I said, difficult to really get a feel, and we'll kind of look at some example of that later. Determining both the horizontal and vertical axis can help us see subtle ECG changes. Obviously, you guys can't give me a quick rundown of how we can determine axis in the field because I am recording this about 2 months before class actually starts and probably 3 months before you guys will actually be listening to these PowerPoints. So We'll look at a couple examples of what I mean by the subtle changes that you can note in an EKG by determining the axis here. Noting that the left axis, noting left axis deviation can help you spot really subtle inferior MIs whenever you have a very small amount of ST elevation. It makes it easier to remember to look for that ST elevation when you do see the left axis deviation. Also, pacemakers in the apex that are located, and you guys remember when we talked about pace rhythms, pacemaker spikes whenever the apex of the right ventricle, placed in the apex of the right ventricle, they can be real difficult to spot. So if you see a left bundle branch block morphology in lead 1 and left axis deviation, this can help you remember to look extra close for pacemaker spikes. Because as I mentioned when we were talking about pace rhythms, sometimes it is very difficult to see these pacemaker spikes with the newer types of pacemakers. They use such a minute amount of electricity. Back in the old days, with pace rhythms, it was really easy to pick them out. They were very distinguishable because the different amperage and electrical voltage that they used. With the newer ones, it's not so easy. They leave a very small trace sometimes, especially with these demand ventricular pacemakers, that it can be really difficult to spot them. So if you don't see that, it can lead you down a path that is incorrect. Just a couple more, just one more examples. Patients with a left bundle branch block and right axis deviation can help us rule in VTach, or specifically right ventricular outflow tachycardia in patients that do have a pacemaker. So if we do have a question about a runaway pacemaker or versus a VTach, this can help us rule in VTach due to where the ectopic focus is located in these type of tachycardias. So these are some examples. They probably don't make a whole lot of sense to you guys right now, but as we go on, be sure to ask questions whenever we're in class, because this is an important feature of the EKG that is lost on a lot of people, and hopefully I can ease that for you guys as we move forward. So here is an example of what I was discussing just a little while ago, with the left axis deviation reminding us to look for very subtle changes in our ST segment in the inferior leads. Noting here we do have the axis deviated to the left. Looking just a quick glance at this EKG, especially from beginners at EKG interpretation, it is very easy to miss the subtle ST elevation in leads 2, 3, and AVF. Noting that the ST segment is just above the isoelectric line, looks like about 2 to 3 millimeters in 3 in AVF, and then a couple millimeters in lead 2. We also have reciprocal changes in 1 in AVL, and this is indicative of a ST elevation MI. This is a heart attack. There is some type of culprit artery, more than likely the right coronary artery, rather the left circumflex, more than likely. But this is just what I was talking about. Looking as we delve into this determination of axis, make sure that you remember why it's important. It's easy to assign a number to a EKG and say what the axis is, but really understand what we're talking about, and that's going to help you pick up subtle things like this. So the axis is the general or average direction of electricity flow through the heart. We assign it a numerical value, and for the purpose of this lecture, we are referring to the QRS axis only. You do have a P wave axis, you have a T wave axis, but we're not going to discuss those right now. So normal axis is what? As we've mentioned several times, the normal flow of electricity is down from the right atrium down to the left ventricle. Starting up in the SA node, it travels into the apex of that large left ventricle. So that's the average flow of electricity through the heart. So we assign a numerical value, and we say that anything is normal if it's between -30 and 90. But this really doesn't tell us very much. But looking at this picture here, remember, if we look at our right atrium, where our SA node originates, and it travels down and to the left towards that big left ventricle. Remember, that is our average flow of electricity, starting from the anatomical position, the right atrium, down to the left. So from the right arm towards the left leg. So it'll make a little more sense whenever we are able to put a graphic up that is going to aid us in seeing these numerical values. Okay, so here we have our graphic representation of what we're looking at when we're talking about the vertical plane axis. Note that what we're talking about is only vertical. We also have a horizontal axis, which we will talk about momentarily. But look at the numbers here. We have a circle. That's all it is. We put a circle around the heart, and then we arbitrarily assigned a positive 180 degrees on the bottom, and then a negative 180 degrees on the top. So we have our normal axis sitting anywhere between -30, which is towards the patient's left arm there if you don't see it, and +90, which is going straight down. So any time the average flow of electricity runs in this range, we have a normal axis. Anytime it runs out of this range, we have a abnormal axis. And we'll talk about what is abnormal momentarily. So we do have a chart that is used for determining axis. We can look at two leads and pretty much get a basis of whether the axis is normal or abnormal. We do this by taking lead 1 and lead AVF. We need to determine the deflection of the waves in lead 1 and AVF, and we determine if they're positive or negative, and from that we can find our axis, find if it's normal or not. So if we have a positive deflection in lead 1 and AVF, it's normal. It's from 0 to +90 degrees. If we have a positive deflection in lead 1 but negative in lead AVF, we have to look at lead 2. If lead 2 is also positive, then we have a normal axis. If it's not, then we have left axis deviation. So we have possible left axis deviation if we have a positive deflection of lead 1 and negative of AVF. Now if we have a negative deflection in lead 1, positive in AVF, then we have a right axis deviation. And if we have a negative in both, we have what's called extreme axis deviation, which is directly opposite of where the heart should be. The direction of electricity should be traveling. Not a big fan of that chart. I do think it is a little oversimplified. I do like to show my classes how easy it really is to assign a numerical value to the vertical axis. This method does use some numbers, so a lot of people are scared of it. It really is easy to do. After you do it a few times and practice with it on your EKGs, you should be able to determine your axis fairly easily. Once you commit the charts to memory, it's just a few simple numbers that you need to look at, and you can do it without much effort. You should be able to get to the point where you can do this method without even needing the cheat sheet that you guys have. So let's take a look. This method is going to help you determine the axis within 5 to 10 degrees. This is good enough for anything that we're doing. It is for the frontal or vertical plane only. It is pretty easy. You don't even need the cheat sheet after you do it a few times. So what do we need? What do we need to know? Number one, we have to look at the QRS deflection. We need to determine if our QRS is more above or below the isoelectric line. Above is positive, below is negative. And equiphasic is something we'll talk about in a minute. This is for frontal axis only. We only need our limb leads. We're going to look at leads 1, 2, and 3, AVR, AVL, and AVF. We're going to throw the precordial leads out the window, our V leads. We don't need those for this method. We'll look at a couple examples first. It's important to remember, limb leads always have a positive and a negative electrode. So we've already discussed it. We'll go over it real quick again. We have a chart here. In lead 1, our left arm is the positive electrode and our right arm is the negative. In lead 2, our left leg is the positive electrode and the right arm is the negative electrode. And in lead 3, our left arm is the negative electrode and our left leg is the positive electrode. Remember that our augmented voltage leads use the 3 limbs and Wilson Central Terminal as the negative electrode. So the 3 limbs are the positive electrodes in the augmented voltage leads, which is mentioned here. So we need to look at the EKG. Understand that a positive deflection of a complex is the flow of electricity towards the positive electrode in that lead. So a negative deflection, likewise, is the flow of electricity away from that positive electrode and towards the negative electrode. Looking at our chart down here is a representation of that. Electricity moving towards that positive electrode at the top is going to create a positive deflection. Electricity moving away from that positive electrode is creating a negative deflection, and electricity running perpendicular to that electrode is creating an equiphasic or equilateral deflection. We have the same distance up as we do down. So here we have an example of a left axis deviation, and first we'll talk about the first chart we looked at, which you guys should all have a copy of. And if you look, what it says to do, we're gonna go by the one that I have sitting in front of me. We're gonna look at lead 1, which is a positive deflection. Look at lead 2, which is an equiphasic deflection, and look at 3, which is a negative deflection. So we look at that and we know that our axis is somewhere between 0 and -30, or a physiological left axis. Now, using my method, everybody should have your cheat sheets in front of you. And I know I haven't explained how to do this, but we're just going to go through it like this real fast, and then we'll talk about the method afterwards. So what we want to do is find our most equiphasic lead. The one that is most equal to traveling up and down the same distance. In this example, it's going to be lead 2. Also, it is important to note that most of the time, your smallest amplitude of QRS is going to be the most equiphasic. So if you look at leads 1, 2, and 3, AVR, AVL, and AVF, they all have pretty tall deflections. Lead 1 is about 15, 20, 25 millimeters tall. In comparison, you look at lead 2, which is only about 8 millimeters tall. And lead 2 is our most equiphasic. So what we want to do, we look at our most equiphasic lead, and then we're going to consult our chart. And in our wheel, we want to look for the most, or for the perpendicular lead to lead 2. We know the flow of electricity is running perpendicular to the positive electrode in lead 2. So we'll look at our chart. We find lead 2 on there. And then perpendicular to it is going to be lead AVL. You can also look at the the example where we have the arrows pointing to the perpendicular leads. So then we look at AVL. Now, if you look at the end of the lines on AVL, you'll see that one is plus 150 and the other side is negative 30. The way that we're going to tell which number our axis is by determining if AVL has a more positive or a more negative deflection. So look at AVL and we notice that it does have a more positive deflection. So we look at our chart and we look at with the arrow up, so meaning a more positive deflection, and we can say that our axis is negative 30 degrees which is within 5 to 10 degrees of the exact QRS axis. And which you can consult your chart and know is a physiological axis deviation. So that's really the way to do it, and we'll go through several more examples, but it's really as simple as that. So we'll look at another example. Here we have an example of our right axis deviation. Looking at our leads 1, 2, and 3, we see that lead 1 is negative, lead 2 is about equal negative and positive. And then lead 3 is positive as well. So looking at our chart, we can say that, yeah, he does have right axis deviation. It's from 90 to 180. But using our method that I want to teach here, we're going to look for our most equiphasic lead, which is, again, lead 2. And then perpendicular to lead 2 is lead AVL. AVL is mostly negatively deflected down, so we look at our down arrow, our axis is 150 degrees, which is a right axis deviation. So whenever we look at our wheel with our leads listed on there in the cheat sheet that I gave everybody, what we're really looking at is a representation of the vector where each lead is looking. So as we look at our numbers that are assigned to each lead, if that is the lead where we are looking, then that is the flow of electricity. That's the direction that it's going whenever you put that wheel superimposed on the heart. We do assign a numerical value based on the most equiphasic limb lead. The most equiphasic limb lead, as I've already stated, is running perpendicular to the axis of the heart, meaning electricity flows neither directly towards or away from this vector. So, our example, we want to look for the most equiphasic limb lead. So, out of leads 1, 2, 3, AVR, AVL, and AVF, our most equiphasic limb lead. And I don't know how your guys' computers are. It's kind of hard to tell from mine. I did state that usually the smallest lead or smallest complexes are going to be the most equiphasic. But if you do look in this case in AVL, you do have smaller complexes, but they are completely negative. They don't go above the isoelectric line. So our most equiphasic limb lead is going to be lead 3. Lead 3 has the most equiphasic or isoelectric complexes. Like we said, this means that the heart's axis is running perpendicular to lead 3. To determine our axis, we determine what the most equiphasic limb lead is. It's the lead with the most equal distance above and below the isoelectric line on our QRS complexes. So to determine our value, we're going to consult our chart. So like we said, lead 3 is the most equiphasic, so we want to look for the lead that runs perpendicular to lead 3. This is the line on which the electrical axis is traveling. Now we have AVR, which is perpendicular, and we want to look at AVR, determine if our complexes in AVR are mostly positive or mostly negative. So look at AVR, and we determine that most of our complexes in AVR are mostly positive. and that tells us we have an axis of negative 150 degrees, which is an extreme right axis deviation. Now, in most cases, it's important to remember that extreme right axis deviation, the most common cause is improper limb lead placement. You have your left arm placed on your left leg, or your right arm placed on your right leg or something. You've got limb lead reversal. In this particular case, it doesn't appear to be so. It looks like you have a severe problem with either right ventricular dysplasia or right ventricular hypertrophy to a very extreme level. So that is that's that. But in this case, we have our axis of 150 degrees. Negative 150 degrees, or an extreme right axis deviation. So, putting it all together, again, we're going to find the most equiphasic complex. We know that the axis runs perpendicular to this lead. We'll consult our chart, look at the arrows. Where does the arrow point? That's our axis. So keep the references handy as we go through, and we'll go over a couple examples. All right, so in our example here, we want to find our most equiphasic lead. This is a difficult, somewhat difficult to determine here, but it appears that our most equiphasic lead is going to be lead 1. Lead 1 runs perpendicular with AVF. Look at AVF, and our complexes in AVF are mostly positive, so our axis is 90 degrees. This is a normal axis, but definitely a normal EKG. Okay, moving on. On this particular EKG, we're going to do the same thing. We'll find our most equiphasic lead, which again appears to be lead 2. Lead 2 running perpendicular is lead AVL. Lead AVL is negative. So our axis is 150 degrees. In this example, it looks like we have a tie between lead 2 and AVR. I think the complexes are a little bit shorter in lead 2. Therefore, we're going to go with it as our most equiphasic limb lead. Running perpendicular to lead 2 on our chart would be lead AVL. AVL is mostly positive. Therefore, our axis is negative 30 degrees, or a physiological left axis. In this example, it looks like lead 1 is our most equiphasic. Running perpendicular to lead 1 would be lead AVF. Lead AVF would be positive, which would make our axis plus 90 degrees, or borderline, a borderline right axis deviation. This one's a little bit tough to see, but it looks like AVL is our most equiphasic. Running perpendicular to AVL would be lead 2. Lead 2 is mostly negative, which means our axis is negative 120 degrees, or a far right axis. All right. Looks like lead AVL is our most equiphasic. Lead 2 runs perpendicular. Lead 2 is positively deflected, so our axis is plus 60 degrees, or completely normal. So those are a few examples. And we have a cheat sheet here that you guys can always refer to get you in the ballpark. but it is, I think you'll agree, fairly easy to ascertain our axis and obtain the number. We have discussed so far what has the axis in relation to the vertical or frontal plane. We can also look to determine the horizontal axis by looking at the R wave progression in precordial leads. Our R wave should be mostly negative until V3 or V4, and then it should move to a more positive deflection. This is going to help aid in our diagnosis of right ventricular hypertrophy and left ventricular hypertrophy. We need to ascertain if R wave progression is poor, which way is it rotated. We do this by imagining that we're looking from the bottom of the heart. If our QRS complex is mostly positive in V2, and we're looking from the bottom of the heart, then we can say that the axis is rotated counterclockwise. So looking up at the heart, V2 is more counterclockwise than where it should be turning positive at V3 and V4. So this would be a counterclockwise horizontal axis. If it doesn't turn positive until V6, that would be a clockwise axis. And we'll look at some examples as we discuss left and right ventricular hypertrophy. V6 is the most positive, or V6 is the, where the QRS complexes are mostly positive. Looking from the bottom, this is clockwise from where V3 and V4 would be located. So this would be a clockwise rotated horizontal axis. So now we're going to look at a few causes of left axis deviation here. I have them listed on here. I'm not going to read through all of these, but just know that these are some possibilities and the reasons that we want to look for this axis deviation. It can help us rule in all of these listed here. If you notice, primum ASD, standing for atrial septal defect. This is a congenital defect of the newborn, and it presents with a RSR prime pattern in V1. Left anterior fascicular block, left axis deviation is a component of a left anterior fascicular block, which we will talk about in detail. Just know that whenever you do see left axis deviation, you do need to rule out a left anterior fascicular block. Also note that the horizontally oriented heart, meaning this can be a common finding in people that are short and fat, since they have a large belly. Their diaphragm can push up on that heart and make it kind of sit sideways in the mediastinum, creating a physiological left axis. I don't know if I mentioned the difference of what we're talking about when we say physiological versus a pathological left axis. Physiological is a normal finding for these patients. So if it's from 0 to -30 is our number that we determine to be the axis, this is a physiological left axis. It's a normal finding for them. Anything less than -30, so from -30 to -90, this is a pathological left axis, and generally there's some sort of pathology associated with it. Right axis deviation causes listed here. We have pretty much the same. I'm not going to go through all of them, but just know that these are all possibilities of causes for right axis deviation. Dextrocardia, I don't believe I've mentioned. Dextrocardia is a pretty common, pretty rare finding where the organs in the chest are oriented opposite from a normal person. So the heart actually sits on the opposite side of the chest, and everything is reversed. This is dextrocardia, and then there's also situs inversus, which is everything in the abdominal cavity is also switched to the opposite side as well. So your stomach's on the right side, liver's on the left side, etc. So whenever you listen to heart tones in these patients, you will not hear them very well on the left side. You will hear them much better on the right side, and that's pretty much the way you find it. Left posterior fascicular block is, again, a diagnosis of exclusion here. And then the vertically oriented heart, noted in the tall, thin patient. They're just think about stretching out in vertical length. You're going to have a orienting of that heart to where it's not sitting as much down to the left as it is straight down, up and down. And so you can see some axis shift from that. So extreme axis deviation to the right can be caused by ventricular arrhythmias, hyperkalemia, and severe right ventricular hypertrophy. Most often, like I already stated, one of the more common causes of this is a limb lead reversal, incorrect placement of the limb leads. Moving on from axis deviation. Step 3 of our 7-step method is to check the QRS duration. This is where we check our intervals and note any blocks. We already discussed left and right bundle branch blocks. We already discussed the QT segment and the length of that interval. If anybody has any questions on that, you can either refer to the previous PowerPoints or we can talk about it in class. We're not going to delve too much into that right now. Step 4. This is where we're going to check our PQRST wave morphology. We will check for P mitral or P pulmonale, which we'll look at examples of shortly. These are findings that you'll see in atrial enlargement. We need to check for T-wave inversion or hyperacute T-waves. T-wave inversion meaning is just instead of being in the same direction, deflection of the QRS complex, it's in the opposite direction. This is a good place where we can pick up things such as Brugada syndrome or Welland syndrome, which will be in the next lecture. A couple points on the QRS morphology. Real quick, I just popped this picture in here. I think it's a good aid. I'm not going to really touch too much on P waves. I just want to put this out here so you guys have it available. These are some examples of P waves that you can see, variations. Whenever we are looking at our P waves, the best place to look for them is going to be in lead 2 and V1. That's when we're looking at our P wave morphology. So we look at our P wave up in the normal on this chart. We can have a biphasic P wave in V1, and as long as we have an upright P wave in lead 2, that can be normal. What we have in the second box down, which is going to be indicative of right atrial enlargement, is going to be our what we call P pulmonale. Right atrial enlargement is usually caused by pulmonary hypertension, people with chronic lung problems, etc. So what we're looking for is our peaked P waves in V1 and lead 2. Usually peaked is they're going to be a couple millimeters high as opposed to our general where it's just half and up to a millimeter in height or millimeter and a half in height. we're going to see them a lot taller. They come to a point instead of our normal rounded upright morphology. In the left atrial enlargement, we'll have what we call P mitral, usually caused by increased systemic vascular resistance from hypertension and left ventricular dysfunction. And that's evidenced that by the mitral, the mitral P wave in lead 2, and then a biphasic P wave in V1. And then below that, you see some examples of what you could have with right and left atrial enlargement. Talk about T wave morphology. You look here, and we discussed that our T wave should usually, it should be rounded with 2/3 going up and 1/3 going down. You can have what are, excuse me, you'll hear referred to as non-specific ST-T wave abnormalities. These can be caused by a myriad of things, from interventricular conduction delays to electrolyte derangement. So you see there is a lot of different shapes and forms that our T wave can have. Looking below, this is the first one. There is an example of a T wave that you can see in hyperkalemia. This is going to be our peaked, real tall P waves that are centered. Our repole variant is going to be a normal variant that we'll talk about later. Our ischemic T wave there, anytime we have an inverted T wave, we need to be concerned about ischemia. Our strain pattern T wave is going to be, it can be inverted, not necessarily indicative of ischemia necessarily, but that we do know that there's strain on that ventricle. And then we have an example of what our T wave looks like with a prolonged QT interval. So just know there is a lot of different T waves. They can all mean different things. We'll get into those a little bit more detail, some of those on the next lecture. So looking at the anatomy from the AV node down, you guys remember we talked about left and right bundle branch blocks. So from the AV node down to the bundle of His, we split into the right and left bundles. And we talked about what happens when we have a blockage of one of those bundles. Now, what we didn't discuss at that point was that on the left bundle, we branch off again, and we have the anterior the anterior fascicle and the posterior fascicle. The reason for this, in comparison to the right bundle, the right ventricle, the left ventricle requires so much more electrical innervation due to its increased size, as we've already discussed. So we do have a branch off to where the posterior fascicle supplies the bottom and posterior side of the ventricle, and the anterior fascicle supplying the lateral anterior portions. So what happens is that we can have a block that occurs lower than the left bundle. So when we say that there is a left bundle branch block, what that means, if you look at our graphic here, is there's a block right, somewhere around where the arrow with the left bundle branch block is left bundle branch is located. It's occurring above where the branch is. What happens is can have a fascicle that is blocked. When a block occurs inferior to the left and right bundle, we can have some interesting findings. So these are a left anterior fascicular block, a left posterior fascicular block, or a bifascicular block. And we'll discuss those in more depth. So that's what we're talking about, is when a single one of these fascicles are blocked, or in combination with the other bundle, the right bundle branch. First, we'll look at the causes, which can include myocardial infarction, or Q waves, chronic hypertension, cardiomyopathy. There's a few more. So what we're thinking of when we have a left anterior fascicular block is what we need to have these findings here. We're going to have a supraventricular rhythm, a slightly prolonged QRS duration, but not greater than 0.12 seconds. We'll have left axis deviation. We'll have a Q wave in leads 1 and AVL, but mostly consider lead 1 right now. And we'll have an R wave in lead 3. So, if you guys remember, whenever we were talking about left axis deviation, we said that left anterior fascicular blocks are a diagnosis of exclusion when you do have a left axis deviation. So you need to be looking for this when you do have a left axis deviation. So looking at an example here, we note that we do have a very moderately increased QRS duration. I'm trying to see what our duration here is on the readout. I can't quite see it. But it does appear to be less than 0.12. We have a very small Q wave in lead 1 and AVL in this case. And we have a small R wave in lead 3. So what we're looking for is our initial deflection. Very close look shows that we have a very small, moderate downward deflection in lead 1, which is our Q wave. And then in lead 3, we have a very small positive deflection at the beginning of the QRS, which would be an R wave. So what this shows is that we have a supraventricular rhythm with a sinus rhythm with a left anterior fascicular block. This means, and in isolation, these are not that big of a deal because you have the other fascicle that is able to innervate the ventricle fairly well. But where we see problems is when we have multiple blocks occurring in these fascicles or in combination with the right bundle. So, for example, the left posterior fascicular block is usually not seen in isolation. It's most commonly seen with a right bundle branch block. The reason that you don't see it in isolation very often is because it takes a fairly significant injury to cause this block to occur. If you think about the fascicles, the anterior fascicle is very long and thin, whereas the posterior fascicle is very short and stocky. It's a lot bigger around, so it takes a lot more of a mechanism to block this fascicle. So the criteria for our left posterior fascicular block is going to be right axis deviation, a small R wave with a deep S wave in lead 1, and a small Q wave with tall R waves in lead 2, 3, and AVF. The QRS duration is again going to be slightly prolonged. So we'll take a look at an example here. We see our R wave in lead 1, highlighted there. We have a small Q wave in lead 3, and we do have right axis deviation. A quick test to see if you guys remember here, if you have your cheat sheets handy. Let's go ahead and determine our axis on this particular EKG. So using AVR, which is our most isoelectric or equiphasic lead, we know that lead 3 is the perpendicular lead to AVR, and lead 3 is mostly positive, so our axis is right with a plus 120 degrees. So we do have right axis deviation, which is one of the criteria. So this is an example of the rare posterior fascicular block in isolation. Now, where we run into a problem is when we do have a bifascicular block. And this is where we need to be to have some concern. The reason that we need to show concern is the fact that, and whenever this occurs, we only have one fascicle that's innervating both ventricles. So the most common variation is the left fascicular block with the right bundle branch block. So that means our big right bundle branch supplying our right ventricle, and half of the innervation of the left ventricle is blocked. So we have one fascicle remaining that's innervating both ventricles. This is a problem for us. We can move into what we call a trifascicular block without warning, where we have nothing that's innervating the ventricles at all. And as I stated, the left posterior fascicle is a lot more resilient. And the most common cause of our bifascicular blocks are going to be ischemic heart disease. So here we have our example of a left anterior fascicular block and a right bundle branch block together. We look for our small Q waves. We do have them in AVL, not as noticeable in lead 1. We do have it in AVL. We have an R wave in lead 3 and a deep S wave. And we have our left axis deviation. Looks like our axis is about negative 30 degrees. And we do a right bundle branch block as well. Looking at V1, we notice that our QRS complexes are wider than 0.12 seconds. Using our method of our turn blinkers that we talked about, we go up in deflection on our complexes in V1, so we have a right bundle branch block. You can also look at lead 1 with the deep S wave. There, it almost looks like our ice cream scoop out of lead 1, just at the end of the QRS complex. So we have a right bundle branch block and a left anterior fascicular block, which is an ominous finding. We need to be very concerned and prepared for rapid intervention should that last fascicle become blocked as well. So something that's asked a lot of times is, what does a trifascicular block look like? It's not really possible to distinguish between a trifascicular block and a complete heart block. You guys remember we talked about the complete heart blocks when we were talking about our degrees of heart block in the AV node a couple lectures ago. When we have complete AV dissociation, so this is what that's going to look like. We can't really discern between the two. The only difference is that the block is occurring lower, but still no stimuli are reaching the ventricles. Okay, so moving on to step 5, and we'll get into this. We actually have a pretty significant lecture talking about STEMI mimics. The reason for this is that ST elevation is not a very uncommon finding on the ECG of the chest pain patient. It's very infrequently involving an acute myocardial infarction. So they did a retrospective review of emergency department charts over 3 months, looking at 900 adults with chest pain, and they looked for ST elevation and contiguous leads, 1 millimeter in the limb leads and 2 millimeters in the precordials. And they compared the final diagnosis of MI versus something else. The results of which only 15% of ST elevation patients had a myocardial infarction. 85% had a non-MI diagnosis. So what were they? There's a lot of different things causing these ST elevation mimics, but only 15% of them were MIs. A STEMI mimic was 6 times as likely as a STEMI. MI wasn't even the single most likely cause. So what that says, basically any monkey can recognize ST elevation. But the difficult part of this is recognizing ST elevation and distinguishing it from an MI versus a non-ischemic cause. So that's what we will get into in our next lecture. So this is the end of our first 12-lead lecture. Go ahead and proceed to the quiz to see how you do on it. As always, if anybody has any questions, let me know, and we'll see what we can get sorted out. I hope this has been informative, and look forward to beginning our next lecture on 12-lead EKGs.